guys. Thank you for your time. Appreciate that. We're going to talk about what really is relevant in psychodynamic underpinnings for a disease model. How do we link psychodynamic constructs to the disease model of addiction? All right. So first, before we get there, I just want you to be aware of who we are and why we are. More importantly, we're definitely a company that challenges the behavioral health status quo, and you see that in the emphasis that we place on basically neuroplasticity. We really do believe, and this is incredibly important, we believe that addiction and mental illness are brain diseases that can be remediated, okay? So in much of our training in years gone past, we saw the brain as fairly consolidated by about age 5. And we know now, then people say, wait a minute, adolescents are different. They're kind of different animal. Maybe the brain still is forming, and we kind of move age 5 to like age 21 or so. Now we know from the research that the brain actually probably doesn't fully consolidate until the early 40s, and that there are, the ability for the brain to create new neural pathways. So the why do we exist? We exist because we believe through a national system that uses empirical data, we can create evidence-based interventions to repair brain dysfunction, promote recovery, and brain wellness. That's really our mission statement. That's really who, why, what we are. That's why we exist. So if you're the type of person who really doesn't subscribe to a neuroplasticity model, then we're probably going to be a frustrating group of people to work with, okay? Because that really is our belief system. Now, what I want us to try to go understand today is what are the old psychodynamic assumptions of behavior? How do the constructs explain the relationship between person's history, okay, which is really part of the underpinnings of psychodynamic concepts, and disease, addictions, and then how does psychodynamic constructs apply to a multifaceted model of recovery, and then talk about transference and counter-transference. Okay, this is one of Freud's classics, and this is the whole idea of psychic determinism, right? He believes that there is no such thing as freedom, right? And it's all about determinism. So what does that really mean, determinism? That mental and behavioral responses are caused by a dynamic unconscious. That there are traumas, desires, and conflicts that are continually motivating an individual. And that behavior is actually purposeful, and that's really important, okay, that it's not random. And then later theorists start to talk about, and particularly like you get something like Piaget, starts to talk about all behavior is derived for meaning. This is incredibly important for us as psychologists because when we come across a patient who is disruptive or distracting, we've got to kind of veer on the course of this fellow, this gal is trying to make meaning of their situation. Maybe not effectively and maybe counterproductively, but they're actually trying to interpret their environment. It could be an external environment or an internal experience. So, the idea of man and woman, persons are motivated to make meaning is an important contribution from psychodynamic theory, right? Freud is a product of his time, right? He doesn't really see free will. He does believe that things are determined, all right? And of course, among the many criticisms is he's incredibly fatalistic and that life is futile, okay? But he does see that behavior is a willful, determined experience. Now this becomes really important to us, that the public self is a reflection of the internal dynamic, okay? So what you see in an individual is really a reflection of what's going on inside. And this starts to get to how we interpret behavior. This is part of what sets us apart from a layperson, okay, is our ability to interpret the overt in terms of what's going on in the covert, right? That's what makes us different. Right? You recall from Freud, we have an id, an ego, and a superego. Those are just names.
Just a quick question. You made the comment that Freud was kind of the result of his environment in regards to him not believing that freedom was an actual reality. What exactly do you mean by that?
Well, if you think about the contextual time of Freud, right? You know, there's the wars are going on,
Mhm.
you know, the World War I, there's some of the pre-Hitler experience. So we're seeing a lot of kind of cultural, you know, influences that are, you know, constricting folks.
Got it.
Yeah.
Which is interesting, don't you think? Because if you think back to then, they had more freedoms back then than we have now.
Well, I don't do that.
Yeah, I think so. I mean, we're
Freud
very
himself was on a lot of coke.
right. Well, you know, we're very restricted in our daily environment. You know, there's more rules and regulations. You could do a lot more things back in those days. But
He moves from Eastern Europe to Victorian England.
Mhm.
There wasn't a lot of freedom in
That's
Victorian
true.
England,
That's
right? I mean, it was a pretty, you know, constricted world.
Got it.
But it's interesting that perhaps he was, you know, even acting out of his own conflict.
Right.
You know.
Right.
So he just names experiences as id, ego, and superego, okay? But the thing I think is neat is that it's very dynamic. He's really aware that there's conflict inside. Now, is that a reflection of the social conflicts that he experiences as well? But he's aware that there's this churning inside the human condition, okay? And, you know, is that, you know, how do you quantify that? How do you really, you know, use empirical data to support that? He is, you know, that's one of the limits of, right, of psychoanalysis, psychodynamic theory. But it kind of is, there's something intuitive about this, all right? So you go through the you know, the evolution of the psychodynamic theorists. You have Jung, you have Freud coming down, the other Freud, you have Erickson, okay? So you just see, you know, the development of some of the different theories that come out of psychodynamic thought. Now, what we're going to focus a little bit more on is, you know, object relations psychology is really important, particularly in what we do, okay, because it really speaks to our ability to manage the transference. But we're going to speak a lot more about the Dvorsky's work, the supportive expressive, the core conflictual relationship. This is kind of the, you know, an overview of some of the theories, right? This, you know, this is what Freud says, right? Trauma. We all have trauma. We don't mean trauma with a big T, you know, trauma experiences, right? That create these emotions that don't die, they're buried, and they come out. Now, I love uglier. I don't know, I mean, that's Freud. I mean, that's Freud's ugliness, I suppose. But I'm not sure they all have to come out in uglier ways. But we have unexpressed emotions that don't die, they get buried, hence defense mechanism, right? And they come out later on. This is what we believe from a psychodynamic experience, all right? Again, think about this in terms of things are not random, right? Things are kind of determined.
Psychic determinism.
Yeah, you can just see where this is. Now, of course, a strict behaviorist has no time for this. But in our experience, when you think about the folks that you deal with, you know, virtually every one of them, isn't this what we try to get to? We try to get the unexpressed emotion expressed in a way that is not expressed, well, uglier, right? We don't want folks to act out in ways that are going to be sabotaging themselves. So just to summarize, the causes and origins of behavior are in the unconscious. Okay, the behavior has a reason, and there's a conflict. And this to me is really important, that adult behavior, okay, including our problems, are rooted in childhood experiences. Now this becomes really important for therapy, because we do go back and we say, you know, that you currently now are a product of a series of experiences. All right? Most of us were trained that way. I personally believe, can you cut this out? You can, and can you focus on the here and now and be a strict behaviorist? You probably can. But I subscribe to the other belief that they will still come out. Now some might say, maybe this is why there's such high relapse rates. Because maybe the dual diagnosis programs that don't have a good mental health program component are not getting to this. And that's my argument. That's what I believe. I believe there's a lot of people out there who don't have a clue as to how to get to the unexpressed emotion and how that get processed, whatever the word process means.
This really supports the ACEs study of Kaiser.
Yeah, it does. I
100%
see, yeah, right. So we have limitations to psychodynamic theory, and you know, as psychologists, we always have to point out the limitations as well as the benefits. So we know that it was based on a lot of anecdotal work. It doesn't really speak to free will at all. He actually got past the middle-aged bias of women and started to expand some of his work. It does not, I don't think, and I think this is a product of the time, doesn't really understand the role of cognition. And it was much more of this intrapsychic turmoil model. And you know, it's one of those things that you have a theory that prove it wrong. How are you going to prove me wrong, right? It's based on all these anecdotal theories, if you will. But it does really take a human behavior, an explanation of human behavior into a different realm. And I think it does a lot to respect a person's history, which I think is really, I never hear people talk about, at least Freud paid attention to your past and your cultural context, which I think is probably one of the good things. Now, so what is addiction? This is, there's this fellow here, Gabor Mate, who's up in Vancouver. You know, he's, to me, is spot on. That addiction, we call it a disease, but perhaps it's more like a process, okay? And what I like about this is it's speaking to that it's a process that began back then and continues to get reinforced over time, all right? And that's kind of what the whole idea of an additive. If I put you know, in my own research, if we put children who were born addicted to cocaine and kept them in a drug-seeking environment, those kids did very poorly. They just had one additive effect of the trauma after another. We took those kids out of the cocaine-using environment and put them into a non-using environment. Those kids did as well as their non-addicted classmates. So we do know that experience is really important here. And I think that this is kind of what he's getting at. It's a process that involves the physiologic, the emotional, the brain, and the social all together. All right? So in disease model, we talk about dysfunctional physiological brain circuitry. We say that those result in pathological effects, and they're characterized by relapse. So addiction from a disease model is the brain, particularly the dopamine receptors, become hypersensitive, okay? They become excitatory. And that's what makes this thing a disease. So for the non-addicted, one beer, okay, just as one beer. It keeps the dopamine receptors aren't firing. For an addict, one beer sends those dopamine receptors off the charts. And they need more and more and more. And what happens is, this is why when you ask an addict, what did you used to do before your addiction for fun? All right? And they tell you, I used to, you know, watch the Dodgers. And you ask them now, when was the last time you watched the Dodgers? And they'll tell you, and you'll say to them, were you drinking when you watched the Dodgers? When was the last time you watched the Dodgers sober? And this is what happens with addiction, is the previously enjoyable activity no longer excites the dopamine receptors. That's why it's so hard to get people to come up with other behaviors. That's why sobriety here, what this place should be, is an incubator. It should just be teaching people's brains to cool out, chill out, and everybody here should have a little plan. You, as therapists, you should be saying to them, what do you like to do? And we should start to introduce them back to what they used to like to do. This, I am telling you, this is a huge problem for an addict. The previously enjoyable activity no longer brings them that same excitatory dopamine response. It just doesn't. They've replaced it with a substance. It's why their wife is boring to them. It's why baseball is boring to them. The gym is boring. Everything is just doesn't have it anymore. Not because they're emotionally thrill-seeking. It's the brain just not getting jazzed up anymore. Music, the movies, whatever it was. Really, really tough in therapy to try to replace that addiction, that substance. So we want to look at the experience, right? Behaviors are symptoms. Now, in psychodynamic thought, we believe that. Behaviors reflect, again, the internal experience and not the core. Disease, what you see in front of you in your office, is the end point of a process. So you can choose to focus on the end point, or do you back up and start to figure out where in this process should I intervene so that I can make sense out of the process in the present moment to this patient, okay? But it's, to me, you have to understand the patient's history, their context, okay? It's a disease or a process with features of a disease. I really think the idea of addiction as process is important. For those of us, right now, the vernacular is to say the disease model. So that's fine, say the disease model, but understand disease itself as a process. Somebody doesn't develop cancer overnight. Cancer's been building. It's a process. Diabetes has been building. At some point, you could have intervened in the diabetes. You could have lost weight, you could have, stopped your carbs, whatever. You could have gone to the gym, you could have intervened. So with this, right now, in our offices, we're seeing people at the end. In order for them to perhaps not relapse and learn new, I think we have to go back and say, let's look at this. Where did this come from? How did this happen? All right? So again, this is Mele. Now, we've got to be careful in our field when we use the word trauma. It doesn't necessarily mean a PTSD trauma or physical abuse trauma. A trauma is something that just overwhelms, the individual. Okay, it's not judgmental. Okay, but for me, what might be a trauma might not be a trauma for you. You may have been more resilient at the point in time when the event occurred. So we've got to be really, really careful that we don't, judge people's experience or reaction to a trauma. Okay, but I think what he is saying is that, and man, when you start taking histories of people, find one of these folks who doesn't have a wound, an intrapsychic wound, a hurt. They all do. Everybody, well, we all do, right? But we don't all become addicts. But we know that everyone who comes into our office with some kind of an addiction has some kind of an unmet need going on there. Some kind of a longing, some kind of a passion, some kind of a hurt that is not healed, if you will, okay? And we believe in a psychodynamic, as that other slide showed, that it's uncovering that wound and its source is important to healing. Not just simply the act of insight, okay? It doesn't end with insight, but insight is an important part of the pie here, all right? So, in psychodynamic thought, any action, drug, person, anything at all that relieves pain or provides pleasure can be an object of dependence. And we want some of that, right, in early childhood. We want that. We want the infant to depend. That's a good thing, all right? But we don't want a dependent adult. At some point, the ego needs to take over. And that's part of what you're doing in therapy is you're being an adjunctive ego. And that's pretty much your role, is to help shore up somebody else's dependence so that they can become independent. All right? I always find, and I haven't really, this is I think an article somewhere, but how is the Freudian idea of repetition compulsion another phrase for addiction? And I don't know that, but I just think there's something about, we know that habit is kind of just a repeated neural pathway. I mean, from a brain perspective, that's how a habit occurs, right? So how is that related to Freud saw repeated behaviors, repetition, compulsion, as a way of mastering, as a mastery. If I keep on doing it, keep on doing it, keep on doing it, I'll get it right. That was his, his understanding of it, right? Therapy is really interesting because now what you're doing in therapy is you're taking the addiction, the dependence, away from the individual. Okay, he no longer has here, ostensibly, he no longer has his substance, his drug, his gambling, and whatever it is, he's got you instead. All right, so this is the role that we start to play. We're now the new object. The object is not the beer or the vodka or the gambling, it's us. Now that's the beauty of an inpatient setting. Now imagine when you have an outpatient, patient who you see maybe you can get twice a week, but usually once a week. You got 1 hour, and he's got the rest of the week to act out. So you can see where this environment actually can, theoretically can do a whole lot of good. All right. Now, okay. These are the concepts I believe you need to be very aware of. Okay, and I subscribe to the protective hypothesis. Absolutely, I know certainly strict behaviorists wouldn't, but what it says is that the unconscious is active and is trying to interpret, is trying to make meaning. If you do a Rorschach and you see what you get from the Rorschach, you look at the perceptual accuracy. That's always the thing that you need to go after, because that's going to be the foundation of the rest of this person's being. We like to kind of play around with the content. Don't worry about the content. Look at the perceptual accuracy. How is this person perceiving stimuli? Because that's a brain function. And then how is he interpreting it? Okay? And that's really where you want to go, because that's going to tell you how they're going to respond to you in therapy. It's always nice to have a Rorschach before you get to do the therapy.
Also, what stimuli they're actually attracted to can give you some really good information as well.
Mm-hmm. I think the most interesting thing if you use the Rorschach and you use the I guess it's the new Exner, and you get this one printout that this is really a wild one where the person perceives accurately, so the perceptual accuracy is pretty good, but then their interpretation is a deliberate twist. So they come in and they see something that is perfectly accurate, but when they produce the data, they've twisted it. It's almost like a deliberate self-sabotage, which is it's pretty diagnostic. It'll give you a little bit of antisocial stuff going on there. It's pretty interesting. In psychodynamics, we talk about the transference, which we'll get to in a little bit. We talk about developmental level and meaning making. And this is something where the post-Freudians were really good about. They began to understand that the development proceeds fairly in a stepwise fashion, the stage theorist. That was not always the case. Prior to that, right, we saw children as little adults. But they began to understand, no, there's something going on here in a stepwise fashion. Right? The development progresses. We talk in Freudian or psychodynamic folks talk about insight and childhood experiences, which were often ignored. Certainly in the roots of, you think about the roots of psychology as being philosophy, there was not a whole lot of time for childhood experiences. People just didn't go in that direction. And we talk, of course, about defense mechanisms. So these are all concepts that as you're starting to conceptualize and your cases and look at the psychopathology, this is where you need to start looking. Okay, I would really say to you that don't discount the role of early childhood experiences. And you're going to have to figure out a way to conceptualize that or promote that in a way that's going to get you reimbursed, if you will. But don't ignore it, because insurance companies don't want to hear about what happened when this patient was 3. You can't ignore that. It helps to bring the patient to where he is. Go back to disease model as process, okay? Now, this is important in history. Psychodynamic and Freudians have always talked about making the unconscious conscious, as if self-awareness was going to turn on the aha moment light bulb. It doesn't. It doesn't. However, I believe change without awareness is not going to happen. But you can't stop at self-awareness. It doesn't automatically produce change, right? We have to understand the effect of the past on the present, and this now becomes a real challenge with addicts. Particularly addicts whose cognitive functioning is somewhat compromised, because now you're going to ask them to make links, and you're going to ask them to see consequential thinking. And how many, don't you wonder, all these people who come in and tell you how wonderful their families are, and they are absolute train wrecks? And I sit there and say, oh yeah, I'm sure. Oh yeah. My mother was the best in the world. She only drank 5 nights a week. I always wonder when they come in here with these glowing family histories, and that's not true. It doesn't work that way. All of our families have trauma and difficulties, but folks who come from a lot of disruption and a lot of imperfect attachment are more at risk. But of course, not everybody with an imperfect attachment becomes an alcoholic, which now speaks to the brain. Okay, but the point being that we have to understand the role of the past. This sounds very, Victorian, I suppose. Examine unresolved conflicts and symptoms from past, okay, blah, blah, blah. That is part of what therapy wants to do. It wants to say, how does your current behavior reflect what you went through in the past? What is the relationship? Because keep in mind, as in psychodynamics, you see things as a thread. You don't see things as little disjointed, unrelated events. You see things as a thread. There's a commonality that's going through. That's the basis of transference. That you are the latest in a series of objects this patient has encountered. It's now your turn, right? But he's done this before, or she's behaved this way before. You're not the first, okay? And that's kind of what this is talking about. Okay? Liborsky tries to rescue, and I think he does a pretty good job, tries to rescue psychodynamics from the sewer of, of reimbursement. He says, that, okay, supportive, and if you think about it as you want to maintain the client's functioning, you support the client, remember that's the one pole of the Marshall-Linehan DBT, where you support, okay, you acknowledge. Okay, you don't judge their experience. And expressive is your action to try to get the client to understand and express their problems and conflicts. Again, there's a little bit on the insight spectrum. Okay, so that's probably one of the better techniques, and we like it because it can be open-ended or it can be time-limited. We'll do it in 8 sessions or 12 sessions. Right? What are the requisites? You have to have a good therapeutic alliance. And Liborsky starts talking about this thing called the core relationship, core conflictual relationship. So you want to understand how the patient's symptoms, that's his behaviors that brought him to you, fits into his relationship pattern, that's the transference. Okay? So you want to, talk about separation and therapy termination, okay? And that's going to be kind of one of the issues in supportive expressive psychotherapy, is how are they going to deal with the termination, okay? It's just one of the requisites that you have to be aware of when you're using this technique, okay? Think about developmental approaches. We want to interpret in a way that the client can understand. That's not easy when you're dealing with a heroin addict with a 3rd grade education who has spent, the past 20 years with a needle in his neck, okay? But somehow you've got to do that. You've got to be able to get the patient to understand at a level that's developmentally appropriate. Now, this is the key to us, as therapists. We come into this business knowing that we are going to be a transfer object. We don't have a choice. It's just going to happen. And it's going to be based on any number of things, perceived authority, gender, anything. We don't have control over it. It's just the way it is. And we've got to be able to deal with it, because it's going to get tested. we are going to be somebody in their past. Not necessarily the person, but the experience. It's going to mimic what they've known in the past. All right? And Liborsky would say the bottom bullet, that the only way change comes is from establishing the therapeutic alliance, it's from insight, and it's from the ability to internalize, and that's probably the hardest part. How do they take you and your relationship with them and internalize it? That's the introject that Freud would talk about. How are they going to bring you in? Now think about this. That's the experience they haven't had in many dysfunctional histories. They haven't had the person who has been able to give them awareness. The object relations object has not been there, so they haven't done any kind of introject work. You all do. We all do, right? Hopefully, we have some piece of our mom or our dad or our caregiver inside of us that we can call upon. Many of our patients don't have that. So now at 28, you're asking them to kind of accept you as their first introject. Not easy. Not easy, right? For Liborsky, he talks about the core conflictual relationship. This is really, really important. The only way you get to this, you can't say to them in the BPS, next question, what is your core conflictual relationship? It doesn't work like that. It just doesn't. I mean, if you can get maybe an MMPI or maybe a Rorschach, but you become aware of it through the transference. When you start to realize that they're treating you in this way or that way, and that you either are feeling that you're a disappointment to them, or you're feeling anxious with them, you're starting to get to how their relationship issues, what they are. Okay, you start to understand what they experience. Okay, and then that's when you've got to get into the transference. You cannot be afraid of the transference, because that's where all of this lies. It lies in that relationship between the two of you. Okay, now, the self-medicating, negative statements about the self. And this is what you got to be careful. I'm worthless, no one will ever care for me, nobody wants me to be my true self, I'm stupid, I'm gullible, I'm dumb, all of these things they're all red herrings. They're all ways to keep you off kilter. Okay? I'm telling you who I am. This is the core conflictual relationship that they see themselves. I'm telling you, you don't have to worry about this. See, I'm already fessing it up. Okay? I'll tell you, this is the 5th place I've been to. Oh, so what does that mean? Oh, it means I'm going to be at a 6th after I leave here. They're playing their cards, they're telling you how bad they are. Okay? It's kind of like keeping you at a distance. You don't have to do any work, I'll tell you. I'll tell you everything you need to know. It's right there. All right? Don't buy that. There's a wish and a denial that patients have, right? Now, what I think is really interesting is they want to continue to use the substance because the brain craves it without having to endure any consequences. They want love, but they don't want to pay the price for it. They don't want to give up the addiction, okay? Now that tells you how strong the brain circuitry is. There's the very desire and wish to be free of it, and to have love, and to have freedom from the addiction, kind of gets subsumed by the addiction. You often, I'm sure, in the therapy, will come across the patient who portrays themselves as the victim. Okay, that this is all happening to them. Okay, they kind of minimize their own role in the behavior. This is all going on in the core conflictual relationship. So you start to see that these people are very dependent and they're very much a victim. Right? You start to see that, but they won't tell you that. In fact, their bravado would suggest otherwise. They almost come across as antisocial in their bravado. Right? So what do you do in the therapy? Your task is to be a safe and supportive space for them. Okay? You've got, in the transference, you've got to help the brain learn to reinterpret the experiences that they're going to bring to you in a different way. So they're going to act out, but you've got to train their brain by not responding in the way they expect you to. You got to twist it. You've got to do something very, very different because they're expecting you to do what they've always experienced, well, which is not a bad thing, right? I mean, that's what keeps us alive, is we, assess how a situation is going to occur and plan accordingly and stay alive. We run away when the bear comes towards us, right? So, but you've got to kind of twist this up for them. Right? So what is happening in the therapy is really transferential. That's all transference. It's you and the patient. So the attachment experience becomes reactivated. So if they didn't have a very good attachment, or they had an insecure attachment or a variable fluctuating attachment, you're going to experience that. And again, it's one of the values of being in this kind of an environment where there's a milieu and there's a longer term, more intensity. You can get some pretty good transference going on here. You can get some attachment, you can get some fear of attachment. All right. Now, the thing that you need to be comfortable with, and this comes, believe me, this gets easier as you stay in the field, is you just have to get into the transference and not be afraid of it. Because in the beginning, it can be a little bit unnerving, you're really coming across a highly defended person, who can be aggressive and has been antisocial and who's really, again, trying to make meaning in a non-productive way. But what you want to do is you want to be able to experience or actually treat the attachment when it gets reactivated, because you're going to be the person in it. They're going to replay what they've always known. And it's not going to be fair or accurate, but it's what they've always known. And you can't fault them for that. That's their reality. Now, I think, you need to start getting your little phrases down. Things like, what is it like for you when you hear me say? All the motivational interviewing comments. You've got to have them down there. And if you're not comfortable, go in the mirror in your bathroom and hear yourself say them. Practice saying those MI phrases. Okay? What is it like when you think about life 2 years from now? Okay? What is it, what do you feel like when you hear me say, and reflect back? You've got to become, comfortable hearing yourself say these words. All right? I need you to become very aware of your incident reports, because we talk about in psychodynamic and actually in, I think it's PHA, primary process. Do you remember primary process? Okay. Primary process is, the individual's focus on, kind of think of Maslow like 0, Maslow 1. How many times have you read an incident report where there's an argument over who got their meds first? And then you look, and he was 33 and the other one was 38. And you're like, are you serious? This is what you're fighting over? Okay, so when we're talking about people who are fighting over basic needs, food, water, shelter, physical safety, who's first, who's second, who's sitting shotgun, that's stuff that tells you the developmental level of your patient, okay? And go back to your Freudian, your psychodynamic, we need to pay attention to their developmental level. Because now you're going to be in therapy with someone who is so concerned about who's first in line. And here we are, us big psychologists, and we want to cure them, yet they're like Maslow 1. And we're trying to get them to Maslow, the tip of the triangle. We've got to be really, really careful who we're dealing with here, okay? Because that's their reality. We've got to meet them at that level. So what do you say? What is that like for you? Yeah, I heard you were really upset that Joe got into the van first. You don't say, dude, grow up, it's so stupid. What was that like for you? Oh, I never get victim. I never get first. And we told this slide a couple of slides ago, they blame, they're a victim. Well, okay. What's it like when you're never first? What does it feel like? It feels like I feel disrespected. Okay. When have you felt disrespected before? And you get into you start to link the past to the present. Okay. And what I would say at some point in the therapy, if you can get that far, is I would say, tell me what it's like in our therapy. How are you feeling respected or not? and get them to reflect. That's a curveball you throw right at them. Now you're really bringing it into the reality of the situation. You're really taking the transference and you're making it alive. Now that's hard because you don't know what they're going to say. They may turn around and say to you, "You're just like every other one of these lousy therapists I ever had." And you've got to be ready for that. You know, tell me how I am. You know, and again, it's their reality. But if you don't, if you pretend that doesn't exist, you're not doing anybody a service. So you know, you're really bringing that transference alive, which is what you have to do. Okay, because then eventually, what you want to do is you want to get that distortion, and see if there's a way for them to understand how that distortion is in fact a distortion. Okay, but that's really, I'm telling you, those incident reports, I read every one of them, and I'm just astounded by what is getting these people fired up. You know, right? All right. So, in psychodynamic therapy, you know, we have some of the, you know, think about Bandura's role modeling, right? Again, you don't have a choice. You're it. The minute you show up and they show up, you're a role model. Positive or negative. You're a love object or you're a hate object. If you're being ignored, you can kind of guess that you're, you know, the jury's out on you, but they're probably thinking that you're not going to be such a great object for them. All right?
Waiting for you to leave.
Yeah, well, exactly.
And to
Object
prove them
permanence.
right.
They want to test that object permanence, absolutely, which is probably what they're used to, you know. And keep in mind, you know, attachments. If you go back to all your Ainsworth and Bowlby and all that, you know, attachment is not perfect. None of us were attached perfectly. It can't exist, you know. But most of us compensate. Most of us, you know, carry on, and we make our way through. But these are bruised people. For whatever reason, these are bruised people.
In this theory, when do they start testing you? Is it right away, or is it after there's, because in my kind of mind frame, if a client's testing me, that means there's progress, they feel safe enough to do so, and that's actually a good thing. But is that the same in this?
That's kind of, what do you do with the negative transference? Pretty much. And there's, I mean, I believe that as well, that a negative transference is really where the action is. You know, but some folks, you know, again, some folks don't have the ego strength even to test. And then, you know, they just shut down. And then your task is to deal with that,
Right.
You know?
So when you say negative transference, you mean to test?
Well, negative transference is when they take a bad experience from the past and bring it into you. And so could that be a testing? Yeah. It could be a blaming. You know, it could be, you know, you're just in this for the money. You know, you don't really care about me. You know, where they just take their past. It's almost like it's a self-fulfilling prophecy. I know how to handle hurt, they think. I know how to handle rejection, they think. So I will in fact create a scenario where you reject me.
Because at least I caused that, and I'm in control of this.
And
used to
that's
it.
what I'm familiar with.
I'm used to it, exactly.
repetition.
Exactly.
And so they're trying to prove the interject correct.
Yeah, exactly. You ask your patients at some point, how will you know when you're happy? Ask them. They won't even know when, and if they can't answer, say, well, when was the last time you were happy? And if they come up with some kind of a drug experience or addiction experience, like, when was the last time you were happy without a drug or without your compulsion, whatever it is? Ask them. It's a really hard question for them.
Yeah.
You know, because they just don't have that familiarity, that experience. So transference, okay. See, why is transference important? Is because it sets up an intermediary that doesn't exist in your room. There's two chairs, you and the patient. Yet they've introduced a third chair. That is their past. Okay. Now it could be positive, and typically we don't do much with the positive transference, because that probably is not always accurate. But we're not going to get very far with a positive transference. There's it could be denial of the reality. We don't typically interpret positive transference.
So some of this whole third chair that you're talking about, there lead leads to either complementary or concordant countertransference. So
Well,
they're-
countertransference is a little bit different, because that's you. We'll get to that. Transference is what they're bringing to the picnic, okay? So, rather than connecting with you as an individual, they're bringing their dad, or they're bringing their abusive teacher, or they're bringing their experience of the world to the office. So they're coming in with their little suitcase, all right? So you have to figure out, it's really important, you have to figure out who you are in the therapy. You've got to figure this out. How are they relating to me? Is it a power differential? Is it a peer? Am I punitive? Am I a harsh superego? Who they're just waiting to smack me? Well, who am I to them? How do you experience the client? What are you feeling? And that starts to get into the countertransference. I'll get to that in a second. Now, the negative transference is really where the issue, the progress comes from. And that's when they're just bringing all of this negative experience, hurtful experiences into the office, which just doesn't exist. So that tells you, if they're coming out overtly hostile, that just tells you exactly what their experience has been like. Most of the times they'll be kind of non-committal. And bored or disinterested, or I'm just here because I have to be, and you work that through, right? That's not necessarily an overt negative transference, but our goal in treatment is to get them to see that that's not the way this is. That there's a reality here that's a little bit different. That trains the brain to think differently. Okay, so they're not bringing their past into the present moment, which is a distortion. But that's a huge step for them to see you in a different pair of shoes, that you're not the same as the person who hurt them, okay? The repetition compulsion says in therapy that people, what you said earlier, people will recreate what they're familiar with. So if they are familiar with being rejected, they will not say they got fired from their job because they were drinking. They will say they got fired from their job because their boss is a jerk.
Hated them.
And didn't have patience and blah, blah, blah. They will come into your room with the same belief. Since they can't drink in front of you and you can't dismiss them, most of them know that as therapists, we're kind of, ethically obliged to them. They will test the heck out of that. Right? They will test that. They can't drink, so they've got to figure out some other way to alienate you. All right? And you've got to be, aware of that. It's what you said earlier. It's what they know. It's the repetition. That's what has gotten them this far. So now you're going to introduce a new way of thinking, which goes back to what you said earlier. One of the values of being in a milieu is if we can get all the therapists on the same page, then we can all treat this the same way. If we get the case manager and the patient advocate and the therapist and the psychiatrist all understanding and conceptualizing the case in the same way, we all have the same response. We don't freak out when they act out. We all have the same consistency. Okay? Which to me is really important when you start to read these incident reports, and if you're the primary therapist, to become active and say, listen, when he does this, try to understand where this is coming from. He's trying to cope with his environment. We know it's wrong, and we know it's counterproductive, but understand where this is coming from. We're working on this in therapy. So I would encourage you, to the degree that your system allows, to maintain boundaries, but also to kind of cross-pollinate, your interpretation and your understanding of what this patient is going through. Okay? Because you're at a level that perhaps this is very frustrating for the house manager to be able to support the house manager in understanding, this is what this patient is doing. And the house managers are in a really challenging position because those guys are getting this 8 hours a day, well, at least 8 hours a day, right? So, yeah. So, the thing you need to be aware of is, how do you know negative transference might be occurring? One of the ways, other than the overt behavior, right, is in yourself. If you start walking on eggshells, start to make excuses for things you know are not appropriate, okay? If you go the other way and you become a little bit too demanding of the patient, and you treat this patient with more, scrupulousness than the next patient, okay? If you start to become defensive, then you know something's going on in the transference that's probably a little bit on the negative side. And this is going to lead us to the counter-transference, okay? But just to be aware of this, and this isn't bad, it's not bad. It happens, it's part of the relationship. You are in the thick of this relationship with these people. This is why sometimes therapy is exhausting, because you're doing this, 3 and 4 and 5 and 6 times a day. This is a lot, okay? One of the things you need to be careful about is, in an attempt to kind of win over the client, you don't want to become the patient. And you don't want to start revealing to the client, have the client give you advice, have the client tell you, what has worked for him or her. That's not a good thing. That's really not a good thing. All right? So you don't want to go in that direction. All right? If you start to worry too much about the client, okay, are they going to succeed? Are they going to, and you become overly invested, it's not a good sign. Okay? You're allowed to have a boundary. Okay? You don't want to become one undifferentiated ego. You're supposed to be 2 separate egos. All right? All right? And then when you start to overcompensate for the client, and you're at a team meeting, and you start embellishing, and oh, he's not that bad, oh, he really has got a lot of potential. When you start going in that, you're not that, that's not your role as the psychologist, okay? That's not what you're supposed to be doing. You're not the advocate in that regard, okay? That's not what psychology and therapy is about. It's not the same as patient advocacy. Remember, we're in a healing thing. We're trying to repair people at a very deep level, at an intrapsychic level. Think about all that Freudian stuff we talked about, id, ego, superego. We're in the depths. We're not just trying to get them in more toothpaste and deodorant. All right? It's a very different relationship we have with them. Yeah.
I'm still trying to understand the term negative transference. So I'm getting the signs, I'm getting understanding what it's maybe looking like. I'm just trying to understand what the word negative means in that. Does that mean that's when transference is not helpful?
No, that's a good question.
I'm confused by that term.
Yeah, that's a good question. Negative is describing their experience, their past experiences. So negative would be, I'm a guy and I'm of their father's age, and when they come into my office, they automatically recall their father beating them. They're bringing the negative to the present.
It's like undesirable transference.
Yeah, hurtful.
Or adverse or something.
Yeah. So you're a female, and as soon as they come into your office and you're a young female, they see you as the sister who always succeeded, and they were left in the dust. And it's that angry relationship that they're replaying from their sister to you.
Their negative world experiences.
Yep.
Right.
The things that have hurt them, that they have been hurt by.
Okay, and so then I know that that's happening when I'm becoming too demanding or I'm making excuses for the client. That's a symbol to me of okay, they're putting a negative transference on me, meaning something negative from their environment in the past.
Exactly. I'm trying to protect that. I'm trying to protect them from re-experiencing that negativity.
But that's only when we're having.
But that's a bad thing, right?
But that's only when we're having counter-transference with this.
But this is a sign when you see yourself doing that.
Mm-hmm.
Counter-transference is slightly different. We'll talk about that.
Right. I guess what I'm trying to say is it always doesn't have to be that I'm starting to get defensive for there to be negative transference in the room.
Usually it is.
Oh, really?
Yeah.
Oh, okay.
Process of projective identification.
Yeah. Because you've lost somehow the balance, the blank screen that we somewhat want to be sometimes, right? Has been lost because now you're very active. You're trying to protect them from re-experiencing that hurt. So you don't want to protect them from re-experiencing the hurt. What you want to do is correct the perception.
Okay, so I'm trying to follow suit because now I thought I had it, now you just cut me off. Okay, so they come into the room, transference is going to happen no matter what. My dad used to beat me, yada, yada, yada. It becomes negative transference when they bring that same piece in there, my dad used to beat me, yada, yada, yada. And now I'm reacting.
That's the negative transference right there.
Right there, boom. And that's what makes it negative, is when my response is.
Then your response is the counter-transference. Forget your response.
Okay.
The response, the negative transference is what they bring into the room before you even open your mouth, before you have a feeling.
Okay, so it doesn't I don't have to actually be part of it for it to be negative.
Exactly.
Okay. I just
They're
wanted to make sure.
And then I'm identifying with that projection when I'm experiencing some of these things from the
Yes.
last two slides.
Yes.
Got it.
You know it's happening
Mhm.
when you start to behave in a way to protect them from the negative.
And that's what I'm identifying with the projection.
Yeah.
And that's kind of a good thing. And
What-
then I shift to like not
It's good
responding
to-
in that way.
It's good. It's good to be. It's good if you're aware, but it's not good if you continue to protect them.
Right, so that's
Right.
the eclipse, right?
Right.
And then, right,
Mhm.
the eclipse.
Yeah.
And then you like slowly show them that you're
Yeah.
not going to be the, like,
Exactly.
be the exact. Okay.
Exactly.
But the-
you don't want to save them from the negative transference because it is there. You want to correct it. That's Laborski's thing. You want to correct the distortion.
Right.
So the goal before we get to that piece is to understand that the individual's bringing this experience with them and apply the appropriate corrective response with that individual.
Yep.
Okay, got it.
Yep. Yep.
Got it.
And to not be afraid of or scared by or turned off by the content of the negative transference. That's the flaw in some of the treatment programs. That's the challenge that I think that some of the house managers have. The negative transference comes up, it gets acted out, and they're not equipped to handle it.
Well, I mean, isn't it a good sign that they're able to put that on you because they're like trusting you enough to
Well, I
project
think
onto you?
that goes back to your very early comment. Absolutely, that's what we want.
Okay,
Yeah.
because I mean, I think when I get to a space in therapy where my client's like angry at me, I'm like, okay, we're getting somewhere. Like, you're putting your shit on me, and like, now we can like work with that, and I can show you that I'm gonna be different than that and provide a corrective emotional experience.
Yeah, we probably wouldn't term it that. We would probably say you're bringing
Right.
your past experience
I wouldn't say that to the
and
client.
the trauma and hurt of your
Sorry.
past experience to the present moment, but that's true. That's exactly what we want.
Right.
You know, absolutely. And sometimes we get there, sometimes we don't.
Can you go back 2 slides? I want to see something
Mhm.
really quick.
Yeah, which- Whoops.
Oh, man.
That one?
Yeah, that one.
That one?
Yeah.
Mhm. Yep, yep. So that's the negative, you're exactly right though. The negative transference gives us the content of their experience and how it's being continually replayed
Right.
in inappropriate ways.
Okay.
You know? Absolutely. You know, in theory, you would want to then say, after you correct the distortion, you'd want to say, okay, let's talk about how this might play out. That you saw me in this one way, but now you're able to see that it wasn't accurate. So how do you think you can take this to the next relationship that you'll have, which will be at 3 o'clock when you go to art therapy, and you go into that room. What have you learned differently? But you got to get to that point. Absolutely. You cool?
Yeah, thank you.
That role reversal right there, it's almost like the parentified patient.
Well, where the literature is on that. The literature is on folks in recovery being primary therapists to patients in recovery.
Right.
How does that work? Is that recommended or not? There are articles on both sides of that.
Right.
That coin.
Right.
Yeah. Yeah. So countertransference. Now, countertransference occurs in a couple of ways. One is your countertransference, which is your experience. Oh God, when I'm in front of these people like this, they make me feel, this patient makes me feel, blah, blah, blah. So you will find that there will be some diagnostic category of folks who you just don't work with, who just make you, and there's just a bad attachment. It just won't connect. And that's okay. It's just good to know that. so that, you know, you don't actively seek them out or pretend that you can help them because your countertransference gets stirred up. Okay?
Bless you.
So it's all of the experiences that you bring, because you have your own baggage and, you know, suitcase full of experiences.
Are you sure?
And some do.
I thought we
Well,
got rid
unless
of all
you've
that.
been therapized
Right.
yourself. Remember the old days? Well, you don't remember the old days, but the old days we all had to go through therapy.
How many years did you go through?
4.
Alright.
Yeah. But we had a 7-year program, and we had 4 years.
Of
Most
psychoanalysis.
schools still
Right.
require that.
Well, it was psychodynamic.
Okay, yeah.
Yeah.
Yeah, true.
But I mean, that was the whole idea, was that you would get at least in touch with your issues.
Uh-huh.
But the countertransference, however, is important for empathy. You really do have to be able to bring something into the therapy. You're not like a robot. So you are going to have some experience, right? And some reaction. It's important. And as I think I said to you at some point, that whenever you get stuck in therapy, read your own countertransference. It's invariably going to be accurate. So if you don't know what to say, you know, you say to the patient, wow, this can be frustrating, can it? And it's you're feeling frustrated, or you just say that, and invariably you'll get some kind of a positive response. Read your own countertransference; it'll tell you what's happening in the therapy. You know, it really will, unless you're actively psychotic and totally unattached to yourself. Which we'll edit that, right?
Dead inside.
Yeah, right. And so this is the corrective emotional experience when you start to work in the transference and the countertransference. And what it really means is that this is interesting because you as the therapist, you initiate the transference just by being there, and you initiate the countertransference because of your own experience. So you're very active in this therapy, okay? But just be very, very aware that office is really, a sacred, special place, because there's a lot of, emotional exchange, intended and unintended. And you've got to become very comfortable. It can be very hard to just call someone and say, listen, you're saying this, and I need help. You have to help me understand how you're concluding this. And it's hard. It gets really hard when you feel like you're getting nowhere with the patient, and you want to discharge them. Because if you haven't already done that, you will want to get to that point where you're like, this isn't working anymore. And ethically, the guidelines, the ethical guidelines, require us to refer out when we feel as though we've exhausted everything that we can do for this patient. But it's how do you know when you've gotten to that point versus it's your own countertransference of feeling helpless.
When you start celebrating that they don't show up.
That's a really good sign. When you can say, that I'd rather not make money than have to deal with this patient for another hour. I mean, it tells you something though. That's really, really important. See, and we've got to, if you sign up for this career, we've got to be the ones that can kind of tolerate that. It's okay for a lay person, well, not okay, but lay people are not obliged the way we are to the relationship, all right?
I was going to ask something or say something about the dynamic between transference and countertransference. Sometimes it doesn't have to be with past experiences. Maybe bad feelings they're experiencing today or right now, they want to pass it into you because they want to get rid of it. And by you owning it, that's countertransference, or it's not related to. Because when you say negative transference, it doesn't have to be only positive, negative experience with past person in the back, like in their life. What if they have negative experiences or negative emotions right now they're dealing with, and they have pain and suffering inside, they want to pass it to somebody. And in this room, intimate room where they can really share and take this load, just dump it on you and you deal with it. So I don't have to deal with it anymore. And if you accept that and you own it, then you show the countertransference, and now the dynamic is all messed up.
I, I understand that what you're describing. I don't know that counter-transference and transference are the best descriptions of it, but I think what you're describing is there's another rule in therapy, and that's you don't hold the anxiety. It's not your anxiety to hold. You don't, and you do that really a lot in couples therapy when you're doing like marriage counseling, and the families, the couple system is willing to throw you the fireball. You don't hold it. Absolutely don't hold it. It's not your task to hold the anxiety of the patient. It's your task to be there, to be supportive, to help them express, but unless they're decompensating, and I really mean like real decompensating, unless that's the case, when I think you do have to kind of shore them up and be the external ego for them, no, your task is not to hold their anxiety. I agree with that. Yeah. Any other questions, observations? Okay. So hopefully, what you're understanding how that transference experience works. That there is some value still to a lot of the old psychoanalytic or psychodynamic, I should say, concepts. But keep in mind that it's within those four walls of your therapy room that very, very important experiences are occurring. You can't really understate that. I would also encourage you to look at the incident reports to see what your clients, where they're at developmentally, what's triggering them, and why is she got my lipstick and he got my, shaver? Why is that so important? I mean, that really takes you down to the developmental level of where they're at, and that way you can kind of meet them. You know who they are. All right. So, all right. Well, I thank you for your time. I really appreciate it, and continue to do well, do good work out there. All right. And I'm glad you're working with Dr. Joseph. She's a wonderful supervisor. So thank you guys.
Thank you.